a systematic review of disinvestment trials. Not going to talk much about Bayesian stuff, if at all, today, but I will talk a lot about why this interests me. I'm especially glad to talk about this here at THETA because you've done a lot of work on disinvestment, which even when I was here, I wasn't really involved with, and so I would love feedback and assistance. I think that the best way to work, I thought the best way to work this day is to make it a bit of a working meeting on the systematic review and then discuss some of the challenges involved. So Beata made a valiant attempt to name all of these affiliations, and the one thing I learned, you got to keep all the people that pay you happy. So that's why you got to put them all up there. But basically, I work at a hospital-based health technology assessment unit known as Medici, the Center for Medical Evidence, Decision Integrity, and Clinical Impact. And they're funded by the Hospital Foundation, the Sciences Foundation, the Lawson Health Sciences Research Institute, and they do a lot of technology assessment for clinicians and administrators at those hospitals. And then I'm also assistant prof in the Department of Anesthesia, and I teach in a Schulich program in public health. So today's agenda, just a bit of background and motivation for why I'm now so interested in disinvestment, but the disinvestment topic. A bit about the methods thus far for this systematic review and preliminary results and challenges. And that's the part where, I'm looking for advice, guidance, and thoughts. And then some next steps with respect to disinvestment research in general at Western. So background and motivation. So what is disinvestment? Adam Elshaw, I know that Adam was a keynote speaker, I guess, at a conference that THETA put on a few years back now. I was unable to attend, but the process, he defines it as the process of withdrawing partially or completely health resources from those existing healthcare practices, procedures, technologies, and pharmaceuticals that are deemed to deliver no or low health gain and are thus not efficient health resource allocations. The explicit aim is to reallocate these resources to areas of greater clinical and cost effectiveness. And sounds promising, right? There's always a but. There may be important differences in effectiveness and cost effectiveness at different subgroups, providers or institutions, and disinvestment efforts must acknowledge that, and that in reality, complete disinvestment is rare. More technologies are suited to partial retraction. So if I were to kind of summarize, I think what everyone would probably agree about disinvestment, there's great promise, that we can release resources into the healthcare system if we can identify low-value technologies that we're currently using and paying for, or have other opportunity costs, and potentially increase the efficiencies. The challenges are, I think at least, the methods to identify good candidates for disinvestment are underdeveloped. It's really difficult for the very reason that there are actually very few candidates that are good for complete disinvestment. There's always this issue of subgroups and appropriateness. Lack of evidence and uncertainty, that permeates what we do in healthcare decision making. And also the issue of stakeholders and the challenge that people are reluctant to change. When something's in practice, it's very difficult to remove it, even if the evidence indicates that effectiveness is uncertain or potentially harmful. There's vested interests involved. There are several fairly well-known initiatives that are based on the disinvestment framework or idea. In the United Kingdom, there's the Do Not Do list that's been developed, largely resulting from NICE guidance about what does not appear to work in healthcare. They do not have a do-do list, but potentially low-value healthcare practices have been identified for Australia. So there's like a low-value list for Australia. In the United States, there was Choosing Wisely. This is an initiative that took advantage, I guess, of clinicians' own different clinical groups to ask them to identify 5 practices that may not be necessary or that people should think twice about, and that's been adapted in the Canadian context, and that Wendy Levinson leads that effort. So examples like vitamin B12 and folate testing, routine testing, antibiotics for otitis media and ear infections, polysomnography, which I know that THETA has been working on, so home sleep test versus the traditional route. So I've tried to kind of categorize what I think represents all the different types of disinvestment opportunities. Let me know if I've missed anything. Got a couple of slides here. But we want to eliminate ineffective and harmful technologies, and I think most people have no problem with that one. Yes, if it doesn't work, we shouldn't do it. At THETA, there is some work that has been done on looking at this use of malfunctioning medical devices. And so this is very much at the practice level in an organization, when not so much the actual intervention, but sort of the different types of manufacturers or different options available from different manufacturers don't seem to be working to stop that. Then there are things like decreasing frequency of screening or monitoring and testing. And so maybe rather than having an annual well visit to the doctor, maybe you need it only to go every 2 years, or maybe you don't need to go when you're well. Maybe you only go when you don't feel well. Things like screening intervals for cervical cancer screening, etc. And then improving appropriateness. So this is kind of where we get, this is sort of the gray zone that's challenging, improving the targeting to those likely to benefit and decreasing overuse of an intervention in those that are not likely to benefit or more likely to be harmed. Then there's sort of managing care with fewer and lower cost resources, and I know you've done systematic review on decreasing costs of care and that type of thing. Decreasing, in particular, I think, end-of-life care. It's kind of an area that is au courant, and that we want to at least ask questions about the vigor with which we attempt to treat terminal illness, and that maybe we need to scale back the aggressiveness of care at end of life. And then frequency of routine care, treatment of non-fatal conditions with minimal morbidity, like ear infections and that sort of thing. And then shifting across sectors, which kind of is sometimes maybe just a consequence of disinvestment, and maybe not the goal or the intent. And then reducing off-label use of medical devices and other health interventions. So just try to categorize and think about what are the types of things that we're looking at, because each is probably something you have to think about a bit differently. Now, my personal motivation for thinking about this question, I thought I'd highlight. So I teach in a public health, I teach health economics in the School of Public Health. And this infographic is inspired by, you can actually look up Kai Hai's infographic that describes where all health spending goes. And so 5% of it goes to public health, health spending in Canada. And 37% of it combined roughly goes to hospitals. And so that would be roughly about 30% to the hospital itself. And then when you consider the breakdown is to the hospital itself and then all the billings related to hospital care. So it's a huge discrepancy, at least in terms of percentages. And so, the students that I teach in this public health program, I mean, they are inspirational and phenomenal people that I, their motivation. I mean, these are people that have been working in the ministries of health in Zimbabwe and in very low resource settings. People very motivated to overcome inequities in access to care, knowledge about health. They want to help lift the poor out of, poverty and better education, dental screening in the schools. And then I walk across to the hospital where I have all my research meetings, and we have, $1 million robots, right? That the effectiveness for some surgeries hasn't been demonstrated. And it's just a real kind of strange dichotomy that I feel very pointedly because of the context in which I teach, and then in the context in which I do most of the technology assessment related research. And so I have always felt that, you know, we have to make very good decisions about what we spend money on in healthcare. I mean, that's why I'm in this field. But I especially feel that maybe we should consider disinvestment in this setting and really consider reinvestment in other sectors within the health sector. It's been well known for hospital-based technology assessment, those who do it. There are 10 plus units across Canada, I would say, that most of the requests that they get to appraise technology, and this is quite different from the experience I had, you know, in Toronto and in the settings I was working here, are actually to appraise things that are already in use in the hospital. And they come in various ways. I mean, I talked about the $1 million robots; those were gifted. Then, you know, there's not as much control, right, over procurement of different things in the hospital, and they don't necessarily refer everything to technology assessment. And so things start to go wrong, or the administrators become aware of a high-cost item. They ask their HTA unit to appraise it. So this investment is very much a reality of hospital-based technology assessment. And then more recently with the ministry's policy levers of quality-based procedures, essentially the Ministry of Health and Long-Term Care has been experimenting with particular high-cost procedures and suggesting a price that represents a price of care of a service that represents good quality care. I think that I have some challenges with the way they present it. I don't know how much I think they're masking what they're really trying to do by calling it quality-based procedures. They essentially look at the 40th percentile, for instance, for hip arthroplasty, and across the hospitals in Ontario, and suggest that that's where the cost should be to do and perform hip arthroplasty. It's a much more complicated, the funding formula, but they began with cataract surgery and then went on to pilot arthroplasty, and they're looking to expand that. So in addition to the realities in the hospital where things become appraised when they're already in use, there is this policy lever where they are actually being forced for 60% to actually do things cheaper. So for cataract surgery at Western, they started to buy less expensive lenses, for example. So these the QBPs are also bringing in this additional aspect where this disinvestment is quite a reality and more urgent. And we get referred questions like, can you help the orthopedic surgeons do hip arthroplasty cheaper? Okay. So the questions, because of this, and because of the context in which I work now, what methods have been used to appraise disinvestment opportunities? These are the questions that came to my mind. You know, experimental, observational, decision modeling, and what are the findings? And how then do we get learn from that to move forward to do our jobs better? So I'm presenting a preliminary protocol for systematic review, and I'd like your feedback. I mean, Young is here. He's the undergrad student who's helping me with that this summer, as well as others. And we are attempting to do a systematic review of the literature to identify trials that have a disinvestment. I start with trials because they're easiest to identify, but I think also non-randomized studies would be of use, but harder to identify. So we started off with a few the key databases and trial registries. We started off with just a disinvestment search strategy that's been used previously, and just kind of all these terms, unnecessary in technology assessment, and as well combining it with the divest, obsolete, reassess, reallocate, and disuse. We have this inclusion criteria initially, okay? And I'll get back to the search strategy when I talk a bit about what we found, because I think there's a possibility to expand this and make it really large, or focus it and make it small. So we're looking for randomized controlled trials just initially because that's feasible in the short term, and we can build on it for non-randomized studies in the future. Human subjects, where the objective is to assess the safety, efficacy, and/or acceptability of ceasing the use of a particular resource or intervention, reducing the use, reducing exposure to a potentially harmful diagnostic or therapeutic procedure, or substituting a less expensive or less resource-intensive alternative. So like a less expensive device, like the cataract lenses, or maybe lower cost personnel. So this is potentially extremely broad, right? And I don't think we searched in a way that would, targeted way that would get all of the things that this criteria suggests would be relevant. And, you know, we did face that. But anyway, so exclusion criteria, you know, no abstract, not an original study, not an RCT, conference proceedings, non-human subjects. Public health, I mean, it was just a few public health studies came up, and it was just challenging to think of it in the context. So we restricted it to non-public health. And then there are tons of studies, RCTs, and, you know, the vast majority of them where, you know, the role of resource use or exposure to harmful procedures is unclear, or at least it wasn't clear that that was what they were trying to ascertain. Or the resource use, decreased exposure to harmful procedures, etc., was incidental and not the trial objective, because that would just be too much, and I don't think the point. We're trying to find people that have done the things that we want to do, which is do trial disinvestment. So data abstraction, you know, typical stuff like publication information in the unit of randomization, et cetera, the type of technology, the relevant PCOs, and so on. And then try to categorize, you know, what were they trying to do? Completely stop or reduce use, or were they just trying to lower overall costs and that kind of thing? So preliminary results and challenges, and this is where I open the floor for a discussion. Well, you're welcome to interrupt anytime, actually, but so we found 1,000 plus abstracts. Currently, we have about 20, well, actually 27 included, or 29, and others. But I think at this stage, it became clear that this idea of disinvestment, it's challenging, I think, in general to define precisely because so many things can overlap, and it can be potentially broad. So here's what I think, an abstract that I think is kind of the target thing that I was looking for, the type of routine daily chest radiographs versus only if warranted. I don't know to what extent this is a pertinent clinical question for every ICU, but this was for the ICU for these authors. And so they did a cluster randomized trial and randomly assigned some units to the routine chest radiographs and some to do on-demand strategy. And they were looking at the reduction they were looking at the number of radiographs that were ordered. And so that the on-demand strategy was a preference to this routine strategy. And so this is kind of sort of the kind of thing that the hospital would be thinking of and that we would be looking for. I think some of the challenges we run into, and I'm sure you've grappled with before, so they overlap with quality improvement and the kind of understanding that not all quality improvement is going to be disinvestment, but understanding within that subset, which is the overlap with cost reduction in general, like sort of generic reducing length of stay or getting patients through faster, which could also be a quality of improvement. And then also decision support. So there were a few that were decision support trials that used computerized decision support to indicate to clinicians that they may have been ordering tests that were redundant, et cetera. And then also patient decision aids, because you can actually come at disinvestment potentially, by targeting the patient and getting them to better understand the options that might be lower resource or less harmful. So there's a great possibility to either broaden or narrow. And then as well, it's challenging to understand the maturity of knowledge. So for instance, if a particular trial was appraising disinvestment but didn't specifically say that, because we know from some specific clinical context that we've been dealing with, I know of some papers that really was a disinvestment trial, but there's no way from the abstract that you would be able to tell that. So is it even worth trying to be this broad and maybe trying to approach it more from a specific clinical question about disinvestment? So I'll pause there because I see Murray furrowing his brow. I don't know if you tackled this when before. Yeah.
Well, something that thing that there is a primary focus on saving money.
Yeah.
And it may be some of these other things too. Quality, program, blah, blah. But it seems like the major motivation is investment. Way from other kind of quality improvement, health investment, any of these other things. Quality, whatever. It's the primary focus. Is that wrong?
I wouldn't say it's wrong. I think it's right. I think where then does something fall in where there's no reference to cost, but we're looking at exposure to harmful therapies. There's an implicit reference to cost, perhaps, but like too many X-rays or right, which is.
Disinvestment means that you are going to stop.
Mm-hmm.
Right? And then if the other thing happens, right, put primary focus on reduction of utilization.
There is an implicit assumption that you're not going to worsen healthcare. Easily reduce costs just by, without doing the study, just by saying we're not going to do this anymore. You know, this study showed the abstract. I was surprised there's nothing there about the patient outcomes at all. It's not surprising to me if you say we're going to do on-demand X-rays, you'll do fewer than if you do them every day.
Right.
So what if the patients do worse? Is that a successful trial?
Mm-hmm.
But I don't think you can really just, I mean, I don't know.
No, it's not that those other things aren't relevant. They are. It's what primary motivation. And when you evaluate any health, you evaluate the health and cost.
No, that's useful.
My next question sort of goes back to then the context and where would this be used, and so is the goal really to help hospitals make decisions, or is it even further downstream to like the end funder, like health? Because I think what interested me more extreme from the clinical side, like the choosing wisely. And this kind of work you're talking about here is the hospital can say, hey, we can make a change in our practice guidelines. We can buy cheaper lenses, we can do super images. Versus looking at the cases where the ministry, the funder actually, no more money for this, we don't pay for this. And those cases, I think, are so rare where it actually does get to a point and it's very political. And I think that political process is extremely interesting. I don't know enough. It's such an interesting area, but I don't know enough about what's going on right now in terms of studying it, that all the steps that you have to get through to go through that process of getting to a point where they actually no more money to spend. Mm-hmm. And I work in the ministry, I don't even know how that happens, but it takes a lot, I think, to get to that point where they will not give this before except for in this case, we're going to schedule, we're going to change, the fee code, we're going to change all that. Mm-hmm. Those are very, like, that would be, I think, a very small number of cases if you're
right.
Jurisdiction in Ontario. So I guess I'm wondering if maybe even looking like jurisdictionally or looking at case studies of how does this actually get, looking at that end point of the ministry of where to get disinvested, sort of different than looking at how hospitals
right.
their costs make better.
Yes, no, that's a good point. I mean, that's very rare, the delisting, and it's political. But I think the situation with the quality-based procedures is interesting in that, you know, they're essentially saying we're only going to pay so much for the procedure, so get your costs under it. So they haven't delisted and said we're not going to buy hips, because they don't buy the hip implants, but they are saying find a way to do it cheaper. So I guess, you know, it's reducing the goal is cost reduction. Yeah. When,
A couple of points. One, I agree with one thing you made that hospitals come out. Clearly, you show reduction in utilization.
mm,
As critical.
yeah.
You're going to the best quality evidence. Help outcomes. Then also distinguishing between policy setting the context versus hospital-based. Because we've been actually involved with a couple of, we would call this where it never came up. It was in the emergency room, we want to reduce costs, or not so much reduce costs, but spend our money more efficiently, and not do a chest X-ray every time a child presents with respiratory.
Right.
So we've done, for example, that we've also evidence to getting a child in the operating room just for an ophthalmological or routine patient. We've done a few of these, but it wasn't so much for reducing costs as much as taking that department's budget, global budget, and allocating.
And so,
Hospital setting is reducing that.
so did you find a lot of evidence about that question, for instance, for the radiographs? Like,
We did that study 2 years ago.
yeah.
Genie on it. No.
No?
There was a lot of prior evidence. But the outcome was very positive, definitely in favor of.
Okay. Made this. Right.
Amount of money that millions of dollars.
Right. Yeah.
My question is, do you actual argument whether you would look at
so I think that's pertinent to economic evaluation of disinvestment, for sure, whether or not society or has a different threshold for investment versus disinvestment. I know that some, like Mike Paulden or done some work on that, but I think it's pertinent to economic evaluation. I haven't gotten yet to looking at how people do economic evaluation of disinvestment. It'd be something I think that I am interested in, but I don't know. I don't know the answer to that. Probably people. I think that they're probably. I think that one would have to save a lot more money with a disinvestment decision than. I think the ICER would definitely be different. But anyway. So this was just a abstract of the type of cost reduction strategies that we picked up, but I think didn't target in the search and can if we want to broaden and I guess go along that theme of cost reduction. So essentially looking at how do you bring down length of stay, but there'd be a lot of those. And then also it was challenging, and I think this is the question, the maturity level of the data. I don't know if I'm even phrasing the question properly. It's kind of challenging because I think with Wendy's example, for example, there may not have been any evidence to base a decision on. And so when someone's doing a trial on maybe for the first time looking at doing something lower resource intensity, it almost comes across like an efficacy trial and not so much like disinvestment. I don't know. Like, can we do this? And then rather than is it going to be acceptable and safe? But I don't know if that's a distinction that I just worry about, and I'm just too detailed, but or too hung up on the minutia of it. But you know, there are cases where it's clear that the disinvestment ought to occur, and we're really just trying to implement it. And then there are cases where it's not clear whether it's efficacious or safe, and they're just trying to test it. I think both are, but I just found that distinction interesting. Okay, so next step. So we're going to continue with this probably, and then I was interested in an approach to looking at non-randomized studies, because there's a particular example that I'll talk a bit more of about that occurred at in the London hospitals, where they disinvested in hydroxyethyl starches as fluid replacement. So essentially, it's a synthetic fluid that can be used to restore volume when someone is undergoing shock during surgical procedures. They've lost a lot of blood. So instead of saline, one could use the starches. They were much more expensive. They had been around for decades, but at the time they were introduced, hadn't been tested rigorously with RCTs, but they were ubiquitous. Pretty much every hospital does still use them. Systematic review evidence began accumulating that they were actually potentially harmful, causing kidney failure, potentially increased blood transfusion. So the London hospitals made the decision to not purchase it anymore. So that was a complete withdrawal. So another thing, so there are several studies in the literature that were non-randomized, observational studies where they from Germany, where they've done the same thing. They actually looked at the safety and effectiveness of withdrawing. There's nothing in the abstract that would indicate that it had specifically that it was disinvestment. You have to know the clinical area. So it's really challenging if you want to try to go after broadly non-randomized studies of disinvestment. One would probably have to start with the clinical area, and because you wouldn't know from screening an abstract. We're also exploring prospective pragmatic trials of disinvestment in the hospital. There's some challenges associated with that. I'll get to it. And then I'm also very much interested in that question of economic evaluation. How do we do it? What's the threshold and that sort of thing? How has it been done? If anyone's already done a review of that, let me know. So the additional challenges I already mentioned with non-randomized studies, they at least the ones I know of, and I suspect others, would be indexed with very non-specific terms that wouldn't allow you to specifically select them. So it's probably either a really huge review process or one that has to be done from within just a disease with the expertise and the knowledge of what the disinvestment questions are. Maybe links to one of those do not do lists, like looking at a specific area of interest and to see if they've been appraised. I don't know. So we plan to do a retrospective study of the disinvestment that occurred at the London hospitals, where we just look at the clinical and economic impact of disinvesting in these starches using administrative data. The key patient group, and this had been sort of the subgroup issue, that they believed the starches were safe and effective were for cardiac surgery patients. And so that was the challenge. And they're also the easiest to identify as a cohort because of the surgical procedures. And there's not as much RCT evidence specifically on that population. There's RCT evidence on others. So we want to look at the pre-disinvestment era. So when they use the starches, a washout period, post-disinvestment era, and take a look at outcomes using regression analysis, the key outcomes that have been identified from systematic reviews in the Cochrane review. A significant number of studies demonstrating slight increases in the need for renal replacement therapy, acute renal injury, length of stay, in hospital mortality. Slight but significant from the reviews. So we're going to take a look. We are going to just hope that things didn't get worse. I mean, there's obviously challenges with this type of design because of the fact that it's not randomized, it's observational. Things change over time. And then in terms of prospective pragmatic trials, this is something that's new that Meredith Warrenstein was here at U of T and is now at Western, and his expertise is in the area of pragmatic trials, is just the idea that we should and can use the hospital setting to appraise disinvestment questions and test safety and effectiveness. Obviously, there will be challenges with that, but you know, a design has been proposed by Haynes et al. It's pretty, I guess, intuitive, defining clusters by wards or units, and begin with the control, the use of the event intervention, and in stages, randomize those clusters to discontinue. And analyzing whatever your key outcomes are using multi-level modeling to account for the clustering. This was a schematic from that paper on how to promoting this idea of the step wedge, and a colleague has reviewed a paper that they so should be coming out, where they actually did this. They were looking at cluster randomized disinvestment in falls screening tool. So for nurses on the wards, they had been asked to complete a falls screening tool to identify patients at high risk of falling. They thought, well, can we get by if the nurses go on their intuition? That will lower, you know, the amount of time they spend and that sort of thing. So challenges with this sort of pragmatic approach, right, is kind of the feasibility and consent for withdrawal. I mean, what, you know, when patients are admitted to hospital, do you have to consent them for what they might not get? What are those issues? Particularly with the designs, seasonal variation and heterogeneity would be an important factor. And then confounding by implementation. I mean, by, you know, using a tool and then not using it, you know, the whole idea that if you're a nurse on one ward where they've been randomized to use the tool and you're a nurse on another ward where they haven't been, I mean, are you switching in between, you know, it's a complex type of intervention and a complex setting, but those sorts of issues are challenging. How do you consider your outcome if you're doing non-inferiority and equivalence designs? And then what happens if you found out that you couldn't do without what you actually disinvested in? What are those issues with reintroducing, you know, what types of liability? And likely have to look at the data a lot to be sure that you're appropriately addressing those issues. So there are so many challenges, I think, with this area. Effectiveness, safety, what are your outcomes, and appropriateness, feasibility, and acceptability. I think sometimes maybe in the absence of evidence about safety and effectiveness, feasibility and acceptability might be the outcome you use as the primary outcome for a disinvestment trial. For instance, intraoperative monitoring, there's a lot of monitoring that goes on with ultrasound, et cetera. Maybe it's just a question of, is it acceptable to the surgeon or carrying out that procedure to not receive as much information that they usually do? You know, maybe it isn't, if you can't find enough evidence on safety and effectiveness, but feel intuitively like that maybe really it's just about information, you know, is that adequate trial outcome? I think we talked already about economic evaluation. I don't know if anyone's done a synthesis of disinvestment CEA. Is it a counterfactual of investment economic evaluation? You know, we look at the one that wasn't cost effective. You know, what technologies, what are the sources of data used on effectiveness? What are the thresholds of willingness to pay? Are they different than for investment? And the ever-present issue of uncertainty. So I'm going to wrap up. In this hospital setting where I do most of my research, disinvestment is occurring with greater urgency, and appraising the safety, effectiveness, and acceptability of those opportunities is challenging. All assistance is welcome for those who have expertise in this area or are interested. And I'll just acknowledge Young is here. He was assisting me with a review, and others that were involved as well. And I'll open the floor up again. Questions, comments, suggestions? Mhm.
You mentioned the counterfactual, yeah, I mean, that's your approach.
Sorry?
You mentioned the counterfactual.
Right.
Talk, so that
Yeah.
you never.
Right.
Often our comparison, our studies are negative. None of it should walk on. Right. That's why you're.
Mhm. Yeah, I mean, it's somewhat similar to the approach they took with the do not do list, right? They generated those by looking through the nice HTA and identifying those things that were not effective or not, and putting them on the do not. So maybe that's kind of the kind of approach that one could take if one was interested in identifying through economic evaluation what isn't good value for money and invested. I know that Bob's fan about this a lot. Yeah.
It's been a few years back, but
Yeah.
when we looking at the do not do this,
Yeah.
the technologies that are candidates for technology, the evidence is, I believe, three parts.
Mm-hmm.
Whether the technology does not do what it
Mm-hmm.
may do harm,
Right.
and all the use of technology.
Right.
So that part, you may or may not be able to capture the especially
Yeah.
other things is the continuum of introducing new technologies and improving those that are replaced by better technology. Investment is investment in like a
It should
very
be fair.
continuum pathway. And so when people evaluating technology, take for example the case of sleep apnea, the trial that we conducted and registered with clinical trials, for example, there was nothing about this unit. But if this trial turned out to show that our device probably non-inferiority to sleep studies,
Right.
and the investment and how to capture those instances where the removing an obsolete technology might be
Mm-hmm. Right. Yeah. So are you suggesting that this strategy should incorporate this whole issue of the efficacy? It's the other kind of efficacy trial.
Yeah, that's
But it's like
that's
you can't, you can't go through them all.
this investment may be driven a lot based on just the effectiveness and probably won't be able to cover. Second part is there's nothing about this investment, but the testing of the new and better technology really equal the replacement cost.
But that doesn't happen though in practice, right? Because we were just talking about the fact earlier that delisting is rare. So often when something is listed because it's more effective than what's already listed, it doesn't mean that the other thing is delisted necessarily.
Yeah.
Yeah.
When we introducing a technology that text capable, so many times just finding way to reduce instead of way of own might not be necessary completely use case.
Right. Thank you. Sure.
I think I want to go back, like kind of like what Maria said and others, like
Yeah.
how do you define disinvestment and what are you going to get with the search strategy? So it seems like,
Yeah.
This wide range from making this active decision, say vitamin and TFL, to even something,
Mm-hmm.
as opposed to what I think this study example you have shown was more like change of clinical practice. It wasn't
Mhm.
it wasn't like looking at new drugs versus
Right.
current
Yeah.
standard of care. It seems like all the interventions they looked at were part of the current standard of care. You could choose one or the other. So it's more like a change in clinical practice, which in turn may lead to disinvestment. And so before you started to say that you also look at all kind of other study designs, I'm like, so why did you choose to look at RCTs as to say evaluation of those active defenses?
Right.
How those, how
Yeah.
do you follow up, but are
Sure.
just actually less
Yeah.
change and to
No, that's a good.
cost award?
It's a good question. I think that the hospital environment is what's kind of leading me down that road, because I think before I came to work at a hospital-based tech, I thought about delisting. Delisting is not important to them. They have control over what they buy. So they receive, so the idea, I'm looking for people testing a strategy of disinvestment at that practice level, because it's the type of thing that would help the people that we are trying to help make decisions. Because, delisting means nothing in the pretty much, almost nothing in the hospital setting, almost. So certainly the procedures that physicians can bill for, et cetera, but they're not going to delist entire procedures. What they are doing is do it cheaper. So I don't know if I answered your question. at least for my context, I guess why I went that way. But
I wonder, like, if the term disinvestment is also receiving that in that
right.
context, because the hospital is not going to say, or maybe that's sort of it, right? We don't want to do this one, that one.
Mm-hmm. Well, it can involve resources, right? I mean, they just stopped buying hydroxyethyl starch. So, whoever wanted it could not get it if they tried, unless they snuck in their own stash. So, it does involve not all, it does involve those similar levers, right? And so maybe that is a frame that we could search for. I don't think very many studies would look at that.
Related to a cost effectiveness, related, in the big scheme of things.
Right. Right.
Or is it a change of practice, quality improvement?
Well, I think I think
May or may not be related.
yeah, I think in theory, cost effectiveness would be a great way to get it. I just think there would be a lot fewer studies. Even the starch stuff, no one's done. Yeah, but even the starch stuff, they've only done kind of the outcome studies. No one's done an economic evaluation. So to inform like practice in the hospital, which is sometimes what they really ask for, which is crazy because it makes me nervous. I mean, to some extent, when you're working in a way that you're advising the ministry, and the ministry makes a recommendation, and that recommendation then has to be taken up or not by an organization, you kind of have a few steps in between you and the actual what happens. But when you're kind of in the middle of it, it's interesting. Ahmed, yeah.
I think one of the things an echo for a lot of it, but
Sure.
me, it's not primarily a clinical question or an economic question.
Okay.
It's a policy question.
Right.
And
Cool.
we're going back into prospect theory and this idea that losses move larger than gain.
Yes.
And so,
Yeah.
a commensurate loss in the sense, a loss, a gain and a corresponding loss of the same amount are not psychologically viewed as the same thing. People really don't like losses.
Mhm.
And
Absolutely.
I think that applies equally well to practitioners as patients.
Yeah.
And so I think there's something there that's worth exploring when we talk about disinvestment. These are I think a lot of what we talk about is framing, where you actually frame something as a efficiency gain or as a disinvestment, sort of shifts it from efficiency gain is framed as a gain, and disinvestment is framed as a loss. So it might be the exact same program, but framed in a very different way.
Right.
And there's also power differences. I mean, if you look, the one investment in this area that always fascinated with me was probably 15 years ago when government stopped paying for physiotherapy,
Right.
physiotherapy,
Yeah.
eye exams. But, you know, the really obvious power thing there was that those were all non-physician.
Yes. I think it was chiropractor.
Admitted chiropractic.
Yeah.
But
Yeah.
so it was in some ways very easy to do that, or easier to do that because
Yeah.
The groups opposing them were less powerful than they've taken on the cost.
Yeah. Absolutely.
So all which
Yeah.
is to say that, you know, the context and
The policy context is key.
policy aspects of this, I think, to sort of just look at the evidence and the economics without looking at the policy, particularly for this question, where you're going to miss.
Right. Thank you. Thank you very much. I appreciate it. No, thank you. Thank you. And thanks.